Hello everyone. A few familiar faces, so it's lovely to meet you, and thank you for having me along today, the PHN, and I'm hoping that this will be an interesting session and there'll be an opportunity to have a few questions at the end. I came up with this topic and then I thought, I'm not actually sure what the principles of palliative care are, but I'll talk about a few things and hopefully we'll extract them along the way about what the principles are. So I think you've already had a session from the lovely Lee Grant on supportive care, and I guess paediatric palliative care has more things in parallel with supportive care in adults than it does probably just about any, other types of palliative care. And I think that's because we would take and accept a referral for any child with a life-limiting or life-threatening condition, no matter what the prognosis. So our cohort of people is mainly people with a non-malignant diagnosis and we'll talk about a little bit more about how that's different from the people with malignant diagnoses. Like all palliative care though, it does include all of those multi-dimensional components of the person. There's social, cultural, emotional, physical, all of those elements. So for us, and look, this is a bit on the, if I say what the philosophy of paediatric palliative care is, it's not like it's written in a book. We are a tiny little subspecialty area that really only barely existed when I started my training in this area. So, like all palliative care, it's a patient and family focus. We aim to provide culturally appropriate care. And look, I'm just going to say that Kate, who does our group supervision, will be very aware of how we navigate all of these sorts of issues in order to stay true to our philosophy. The respectful consultation with our referrers, accessibility, not physical accessibility, but like making ourselves available at the service of others, equity of access, being flexible and reliable, and using whatever means we can to help other healthcare providers to feel more comfortable looking after paediatric patients at the end of their lives, recognising that for most people, just like VAD, it does push a lot of buttons. And recognising really what the parents are doing and what we often are doing are holding all of these things in equal measure, and helping people make the unbearable more bearable. I'm not going to go through this whole long history in the interest of time, but just to say that as with adult palliative care, our beginnings are in the UK, as Jane said, our service started in April 2010. Probably the biggest development that's happened in New South Wales in the last little while has been the opening of the adolescent and young adult hospice in Manly in 2023, which I'll mention briefly a bit more later on in the talk. We cover this area, so not just Hunter New England, but the other two, the Mid-North Coast LHD and Northern New South Wales LHD, mainly by telehealth, mind you, and we don't do, I was here for Charles's talk, and that was, I found very interesting, but yeah, we certainly don't get in the car and drive the distances that the VAD people do. I reckon they've probably got the record for the most kilometres done per month of any service in Hunter, New England at least. And this is a really super old slide, but really that sort of split of the types of patients that might be on our books is very, very similar. So as you can see, the oncology diagnosis only makes up a relatively small percentage of our patients, and most of the other ones are kids with chronic complex disability of various types. And this is just lifted from a a little guideline book from the UK about different types of patients. So I guess for those of you that see paediatric patients of any type, if in doubt, have a chat with us, because lots of kids do have life-limiting illnesses who might benefit from at least some of the resources that my service has available. So we would never automatically knock people back based on a diagnosis. And look, things do change, and it is interesting, you know, the written in there is spinal muscular atrophy type 1, and that was, 10 years ago, it was an absolutely devastating diagnosis, and all the little kiddies with SMA type 1 would die very quickly, like in 12 months or 18 months. But now there's a treatment, and those kids stay alive. So, we have things, even if you reflect back from, earlier on in all of our careers, people used to die very frequently with cystic fibrosis. And now we wouldn't even get a referral for a kid with cystic fibrosis unless there was something else very sinister going on with them. In fact, even adult services wouldn't necessarily get a referral for a young person with cystic fibrosis. So, things do move, and I will talk in a little bit more in a slide to come about the sort of survivorship in cancer as well, and how those new targeted therapies have actually changed the trajectory for cancer diagnoses as well. This is a super, super old slide. Please forgive me, and you can't read any of it, or at least I can't read it here, but basically it's the red line that I'm referring to, and this is about disease trajectories, and the sort of classic disease trajectory for somebody with a malignant diagnosis of progressive disease, before all the things I just talked about, would be going along and then having a rapid decline, pretty predictable. The sort of long-term limitations with intermittent serious episodes is more the sort of, in my patient cohort, it's the kids with severe cerebral palsy and scoliosis and recurrent pneumonias, and they come in with another pneumonia, they have a deterioration, they get a bit better, but never sort of quite regain their previous level of function. And at any unpredictable moment, that deterioration may be the deterioration that leads to their death. But you can't necessarily tell that. And then under the bottom one, the heading is prolonged dwindling, which I guess none of us want, but it's a reality for most of us, which is slowly dribbling down to finally dying. Unless, I guess, we should put in the disease trajectory for VAD, really, shouldn't we? And it was like, sorry. Is Charles still here? Yeah. This is a sort of slide just to recognise that in terms of a role for palliative care, it runs parallel to curative treatment. But as disease progresses, there's more and more of a role for palliative care services. But also bearing in mind that we do have to think about that sort of top triangle on the right, that survivorship in long-term chronic care is a whole another area. And also, obviously, and Kate's already talked, in no way underestimating the significance of bereavement care for both anticipatory and post-death, and particularly for paediatric palliative care services. I think the depth and the devastating nature of the impact on parents' lives who have a child that dies. It's obviously all been researched, but just recognising that is, in many ways, one of the most complicated areas of bereavement follow-up. I was going to just say this because we want people to refer to our service because we sort of rely in many ways on the subspecialists and paediatricians within the LHD, within the hospital setting to think of referring to our service. That's where the vast majority of our referrals come from, but in no way do we not want to get referrals from GPs. So if there's anyone who has a patient that you think might be good for our service, please do get in contact. We would definitely welcome it. But it's a complex space because the paediatricians involved in these kids' care are either have a very intense but short relationship, like the oncology services, or they have quite a longitudinal relationship, which they're a bit sort of possessive of. So just sort of trying to honour that relationship and not in any way undermine that with the patient and family is one of our sort of things that we have to navigate as a team. So I won't go through all of this, but essentially if you think of us, give us a call, but here are some of the things that we might be able to offer. And I'm not going to go through all of the sort of differences of the between paediatric versus adult, but I think one of the key, I guess it's one of the principles really, is that no matter what the sort of level of disability of our paediatric patients are, they're on a developmental trajectory of some description, as well as having the progressive disease and whatever that is unfolding. So it's about accommodating the developmental gains that they might be able to make while they are also living with their life-limiting illness. And I suppose that's not something that's the same in adults because, by the time we're all adults, without sort of, going down the pathway of neuroplasticity and all of that sort of stuff, essentially, you're not going to do much more development. Sorry. And I think the other huge thing is, and again, it sort of goes back to the disease trajectory thing, is that the unpredictable disease course, and that makes those conversations around, your kid's really sick, they're going to go to paediatric intensive care, everybody's very worried, and miraculously, 3 days later they're on the ward, and 2 days later they're discharged home, and you go, oh shit, I got it wrong again. But and all of our families with chronic complex disease, kids with chronic complex disease, have a sort of catalogue of all the times that doctors got it wrong. We've had kids in their 20s who were told at age, when their kid was in a neonatal intensive care unit, that they wouldn't survive 2 months. So the parents are living with this grief, but also sort of ever-eroding trust in the ability of people to predict what's going on with their child. So what we really try to do is, when it comes to the sort of end-of-life stuff, to try to accommodate what the parents and the child, if they're able to speak for themselves, what location of care they want, what they want to have happen, where and how. And we do have, through the our beautiful benefactors, the Nicholas Trust, we have hospice-like rooms in all of the paediatrics wards across the district. Not on the Central Coast, sorry Central Coast guys. But we also have a palliative care room in the neonatal intensive care unit that's been co-designed with some Aboriginal families after recognising that we were really not doing well in the space of looking after dying neonates. Now, how am I doing for time? Okay. Well, I'll just keep on rolling until it's not okay. Symptom management. So I'm not going to go into sort of prescribing and everything too much, but I guess these are what I've extracted from my practice over many years, is really doing the simple things well, using the resources that are available, and remembering the efficacy of non-pharmacological interventions. And I suppose for one of the things that I really believe is that listening itself is a therapeutic intervention, like being in the space, holding the space. Like, you don't necessarily have to fix everything in order to make things feel a bit more healed. So I guess in compassionate communication. But I would say that, like customs, like you're not going to get into the country into the country to explore all the exciting things that there are there unless you get through customs. And I think in terms of a patient, if they have severe symptoms, they're not going to want to go and explore all that other stuff. The family aren't going to want to go and explore all that other stuff unless you at least make some interventions that help with symptom management. And I think our kids do have a high level of symptoms. They're not able to report them either because of their level of their disability or because they're just little kids and they can't put in words what's hurting. I think we often, even in adults as well, we fail to pick up really fatigue and sleep disturbance as symptoms that cause a lot of grief and a lot of distress. And I've already said about the non-pharmacological things. So there's a big long list of stuff that people get. And this is from some research, that was sort of sentinel research that was done in the US over 20 years ago now. But I'm a great believer in being sort of systematic and not being sort of completely diverted and thinking the only symptom we can talk about is pain, but actually ask about all the other things too, with the same sort of inquiring mind about what's causing it, what works, what doesn't, how long does it last, all of that. And I suppose when I'm teaching my junior doctors that I work with, it's like your job's not done if you write something up and walk away. You have to go back and see whether it worked or not. I'll skip that. I'm going to skip that too because I'm sure you all know a reasonable amount about pain management. Breathlessness is probably like one of our most difficult to manage symptoms. It's the same as one of the most difficult to manage symptoms in adults. It probably in our culture is the greatest reason for indication for doing terminal sedation at the end of life is that somebody has intractable breathlessness. And any of you that have seen someone who's struggling with intractable breathlessness will know that you really want to do something about it. You don't want to leave that person in that state. And they don't want to be left there either. I think we underdiagnose delirium in children. We underdiagnose delirium in adults as well, but I think we just assume kids are having a tantrum or they're just they're just sad if they're curled up in a ball. And they do, all kids when they're unwell sort of do a level of regression back to previous developmental stages, but I think we just need to remember that kids can have a delirium too. So, yeah, I've talked about that. So I am just going to, this is a bit of horizon scanning. So my service is actively looking via a project that we're running into expanding into the adolescent and young adult area, sort of probably up to age 30, recognising that young adults often don't fit super well into the sort of older adult sort of models of care. We are, because I'm an authorised VAD practitioner too, I haven't done any VAD. I say I'm a VAD virgin. But we will, I think that all of the services that have adolescents and young adults are a bit anxious about what they will do when their first patients start asking them about VAD, and also anxious about how the parents are going to handle that. And, you know, for a lot of kids that have been sick for a long time, the parents are very used to calling all the shots. So it's going to, once we have a few sort of 18, 19, 20, 21-year-olds, it's going to be challenging, I think. Perinatal palliative care is also sort of an area that we're sort of more established in now, but it is sort of has its own very interesting dynamics. We're looking at trying to be a bit more evidence-based. We've got away for years saying, oh, actually, we can't do research in paediatric palliative care, but we can, actually, and so now we're doing more research. I think there's an increasing role, and many of you will be aware of sort of Charlie Gard case and others from the UK. Really, there's very high risk of really complex legal matters being played out in the media around withdrawal of life-sustaining treatment, where the hospital wants one thing, the parents want another, and it's played out in the media and courts. And I think trying to sort of navigate the early parts of those conflicts before they escalate to the sort of things that can, you know, become household names worldwide, is really important. And I think rather than waiting for the train crash to happen, sort of intervening early, which is where my sort of medical mediation interest comes from, and obviously further development of telehealth given the geographical challenges and the fact that we're not hopping in a car every day like Charles is. And lead, actually, I should mention, 3 minutes, cool. And I just want to mention that for any of you that have any concerns about a kid that might be dying after hours, we run a statewide after hours phone roster. So if you ring any of the children's hospitals, so Ranwick, Westmead or ours here, they have the roster and you get put through to the on-call person. So if you've ever got concerns about symptom management, you think somebody's dying or whatever, we don't do direct to patients and families on that service. I have, for many years, ever since I started, have made my phone number available to the patients and families that are referred to us to ring at any time. And they actually don't ring that much, but it's that thing of parents knowing that there is someone to ring if something really terrible happens at 3 o'clock in the morning. And that's the end of my talk. Questions?
Do we have any questions here in the audience? Oh, one down the back there.
Thanks, Sharon. I was just going to ask, in your bio it says you're an authorised prescriber of VAD, but you work in paediatrics, so do you have a sort of separate focus for when you use VAD, or have you had to use it in the paediatric population?
Oh no, so yeah, definitely have to be 18 or older. So I actually did the training with the view to that adolescent and young adult sort of service development that we were doing. So yeah, you can have a conversation with a less than 18-year-old about VAD, but no part of the process can start until they turn 18.
I was interested in what you said, Sharon. It sort of felt to me like you were saying some of the younger patients you would expect them to look at that as an option once they turned 18.
Yes and no. I think it's down to the fact that it's not, like, VAD isn't actually in people's consciousness. And look, you know, we as the palliative care team would be walking a fairly difficult path with navigating the relationship with parents, unless the parents were sort of 100% on board to start saying, oh, have you ever thought of VAD? Yeah, I mean, like we certainly, as opposed to Victoria where you can't raise it, like medical professionals can raise it for people to consider. I would be trying to, and because I don't think young people have it on their radar at all that it is a possibility.
Thank you. Tricky area. Any other questions from the audience or online? Oh, we have one here.
While I'm aware that as children, the parents have to make the decisions, but do the children get asked about what they want?
Yeah.
I'm just curious about how that works.
It is again one of those fraught areas. I mean, it's not infrequent that we have parents who say, we don't want our child to know. And sometimes there are cultural reasons why, that like disclosure and open discussion around the fact that somebody's dying isn't acceptable. The younger the kid, I guess, the more we're prepared to sort of go with what the parents say. But we can have conversations with the parents around the research which shows that more parents regret having decided to not tell their children that they were dying than the ones who did tell them. So the ones that did tell them felt better. How we navigate it is we say, this is for a kid who's got the sort of developmental status to understand what's going on, which is probably 6 or 7, that we would not lie to them if they ask a direct question of us. But if it's sort of, a bit indirect, and we often talk to the parents about how they might talk to their child to raise that. And we've got some books that we sometimes use to sort of open up that conversation if parents don't even really know how to start. So most parents probably end up being the ones that guide that conversation. We have had some tricky cases over the years where there's been 16-year-olds who are completely with it, who the family have just decided that they will not tell their child, and I was like, oh, this is so hard to navigate. The other thing though is that we have to maintain that therapeutic relationship with the parents because they're going to be around after the kids died, and I suppose if we talk about another one of the sort of principles of palliative care, it's sort of probably no regrets. Like we try to get the parents to a point where they feel like the decisions that they've made, they don't regret.
Thanks, Sharon. We're out of time for questions, but just to say we're so lucky to have had this service in our community for the last 14 years, and maybe we just all spare a thought for the families who've lost a child and appreciate the work you and your team do every day. Thank you.
Thanks, Jane. Thanks, everyone.